Next, I call upon Dr. Parveen. She will be talking to you on diagnosing and approaching the hereditary retinal dystrophies.
That's too long.
Everyone, and I thank Dr. Unikrishnan for giving me this opportunity to be here amongst you early in the morning. And after some very interesting talks, I will complete the algorithm for hereditary retinal disorders, what to do when you come across a case of IRD. So we know IRD are rare form of rare form of diseases, but they are, when collectively seen, they are not so rare. They almost form 20 to 25% of blindness, especially in the working age group, and which is most economically effective group. And the new standard of treatment, as has been recommended by the American Academy of Ophthalmology, includes early diagnosis, characterization of disease, genetic testing and counseling, and familiarity with the ongoing clinical trials for treatment of IRD. The early characterization includes both structural as well as functional assessment, and the functional assessment could be for the visual acuity, color vision, history of night blindness, nystagmus. But I think one of the most important things which you should not miss is refractive error. Almost 54% of the inherited retinal degenerations are associated with the refractive error, and myopia is the most common. Patients with ABCA4 gene defect, patients with congenital stationary night blindness are associated with high myopia. So whenever you see a patient of high myopia without a history of myopia in the family, one of the things you could consider is, and you should ask leading questions of any color vision defects or any night blindness, which can be present, especially tilted disc, tessellated fundus, along with 6 to 7 diopter of myopia is actually pathognomic of CSNB and could have TRPM1 gene mutation. Perimetry is another form of functional assessment, and most importantly, of course, is electrophysiology. But couple of things you must keep in mind is the diagnosis of enhanced S-cone dystrophy. If you see an ERG like this, which has a similar waveform in photopic as well as scotopic readings, it is something which could be because of enhanced S-cone, and a single gene NR2E3 could be responsible for this type of phenotype. So without doing genetic testing, this is diagnostic of this type of ERG. Second, very diagnostic ERG is subnormal or non-recordable photopic responses with supernormal combined responses. So no photopic response, supernormal scotopic happens only in KCNB2. So these couple of things you must keep in mind. Second is fundus photography. Just to give you an example, on your left is the fundus photograph, a 90-degree image, where you could label this patient to have cone dystrophy, but if you see carefully on a wide field photograph, this definitely is not cone dystrophy and is a widespread retinal degeneration, and the underlying pathology here was circle mutation causing retinitis pigmentosa. Not to miss is this fine RPE granularity in a child with an otherwise normal or without pigmentation fundus. Pigmentation takes a while to come, but if you see this kind of fine RPE granularity, I did ask for genetic testing, and this again was circle mutation, which seems to be the common form of mutation for retinitis pigmentosa. Macular colobomatosis kind of condition with RDH12, and of course fundus autofluorescence. When you see a patient of IRD, this is one indication where you must advise a fundus autofluorescence and never miss a typical pattern. A fundus autofluorescence which is abnormal with the peripapillary sparing could be due to underlying ABCA4. So if you do a careful clinical characterization, you already have some possible genes in your mind when you advise genetic testing. Autofluorescence can also tell you whether the disease is progressing. So this is what you call the Robson sign or the Robson ring. As you see it increasing in size, this is what is seen in patients with cone dystrophy, and you see it becoming smaller. You see this in cases of retinitis pigmentosa. Optical coherence tomography, these are some gross examples that the moment you see an OCT like this, you know it is adult onset vitelliform. OCT also shows you the area of ellipsoid zone which is presence, and so visual prognosis can be gauged from this. Some form of IRDs are associated with macular edema, and their presence needs OCT for treatment and follow-up. In fact, the EZ width of about 600 micron is necessary for any kind of gene therapy in future. This is one of the inclusion criteria. So OCT again is going to be vital when you evaluate these patients with IRDs. You must do a fundus photograph, OCT, autofluorescence. Some of these OCTs can be pathognomic again and can show you progression of disease, and if you see this, the prognosis for visual outcome can be poor, and this can be explained. Autosomal dominant RP is associated with vitellomacular interface abnormalities, which could lead to CME and macular hole formation, and this should you think of the moment you see this kind of macular changes with RP, you should think of autosomal dominant RP. So when do you decide to have genetic testing? First and foremost, before you straight away go into blood sample collection for genetic testing, is you look for the family history and try to form a 3-generation pedigree for these patients. In spite of a good clinical study, you can still sometimes miss a lot of gene defects because more than almost 300 genes are known to cause IRD, and there is a significant overlap. So the American Academy Task Force has mentioned that for monogenic diseases like RP and Stargardt's, it is nothing wrong, it is nothing over the board if you advise genetic testing, and genetic testing should be considered. This is standard of care. So what kind of genetic testing? Would you do a whole genome, whole exome, a gene panel, or a single gene? Single gene sometimes can actually be more expensive because if you don't get this, you'll have to ask for another one. And gene panel, they are dedicated gene panels for RP, and then whole exome or whole genome, as the name suggests. We do a whole exome most commonly because almost 80% or 90% of the information and disease-causing variants are present in the exomes. So a whole exome is probably a good way to start with. If you do a whole genome, which is somewhere in most of the countries in UK do a whole genome for these patients, the number of uncertain mutations, you don't know whether they are really responsible for the gene or not, that can be increased, and the interpretation can become extremely difficult. Why do it at all? Why do genetic testing? You may argue that there is no treatment, so you don't need to do, but to accurately prognosticate the disease, to diagnose, to develop genotype-phenotype correlation, you must do, and in children, most importantly, I'll share some examples that it rules out syndromic disease. And this is how the interpretation is done. Usually this is done by a geneticist, so you need not worry too much about it, but some knowledge is important, and interpretation is important because clinical correlation is important. Here, you know, it's an example, typical case where USH2A gene has been seen. This too is typical, but imagine the genetic testing is normal, is not showing any variant. This does not mean that it is not RP, it's just that it may be a novel mutation which has not been seen till now. Another example, this was diagnosed as USH2A, but there's a rapid progression. We know USH2A RP does not cause rapid progression. Why was there decrease in vision? Because there was an additional gene mutation in CRB1 gene as well, and that causes early maculopathy. So an understanding of this type of genotype, phenotype, and complex kind of inheritance can be understood as you do more and more of genotype in your cases. But there are problems, there are pitfalls. Single gene, we know best gene can cause multiple phenotypes, and that is because of variable penetrance. Same here. For Stargardt's disease, we know different gene mutations can cause Stargardt's type of phenotype. In children, most important, as I said, syndromic RP, especially senior loken. As an ophthalmologist, you may be the first one to diagnose that the patient has cone dystrophy. But if you advise a physical examination or if you do genetic testing, senior loken, these are the cases where the children will have acute renal failure and may need renal transplant at first decade of life. And this, again, it is a disease in progression in children, so you have to interpret it very carefully. Just sharing an example, this was an 11-year-old child who was first diagnosed to have achromatopsia, then cone dystrophy, then cone rod dystrophy because the disease was progressing. When I did ask the history, patient gave a history, already have undergone renal transplant at 11 years of age. So suspecting senior Loken syndrome, I had advised genetic testing. Previous genetic testing was actually negative. When we redid it, because I had a strong clinical suspicion, we did find the SEP290 gene, and it is important because the parents were ready to take the child anywhere for gene therapy trials, and gene therapy trial for SEP290 is available. Unfortunately, it is only available for a specific variant. This variant was absent in the child. So actually, we saved at least the child a trip to US to check all these things. So gene testing can be very useful, and we are at a cusp where we can do these things. Another last example of Hermansky-Pudlak, we would have seen so many elmanotic patients, we send them back saying nothing can be done, but you are actually refusing them medical treatment, because if you do genetic testing and it is Hermansky-Pudlak syndrome, patient needs to be counseled for life-threatening conditions like bleeding diathesis, pulmonary fibrosis, which can be associated with albinism. So genetic testing comes with the high responsibility of genetic counseling. So this is my final algorithm, that history and clinical examination should be done. This should be followed by proper imaging techniques and functional assessment. Finally, genetic testing and counseling for these patients to look for eligibility for clinical trials, which may happen more and more in near future. So this is the importance of genotype-phenotype correlation cannot be overemphasized. Thank you.